યસ લાઈવ સ્ટ્રીમિંગ થઈ ગયું YouTube પર.
Bhaskar sir is not able to join somehow.
હા જોઈ લો.
Link, some issue with the link. I don't know. See.
લિંક તો સેમ જ છે ને યાર. લિંક
હા,
તો
એટલે
સેમ જ છે. હા પછી મોકલ ને ખાલી.
મોકલી દીધી, ફરતી મોકલી દીધી.
હા. પેનાલિસ્ટ જોઈન થઈ ગયા બધા મનીષભાઈ?
Almost. Dr. Neha, please change your name.
સમીરભાઈ બાકી ને જોઈન કરો.
Samir bin
Yes, sir. Yes, sir. Doing that.
રાજુ સાહેબ ને એકવાર
આવી ગયા રાજુ સાહેબ. સાહેબ જોઈન થઈ ગયા.
અચ્છા જોઈન થઈ ગયા.
join થઈ ગયા, just admit કરે. હા.
ઓકે હા હા બસ આવી ગયા. ફાઇન.
બસ સમીરભાઈ પણ જોઈન કરે છે.
દર્શકને થઈ વાત?
દર્શક પણ જોઈન કરે છે. વાત થઈ ગઈ.
જયદીપ સાહેબ થઈ ગયા.
Good evening, sir. Jaydeep sir, good evening.
Good evening, good evening, good evening.
ગુડ ઇવનિંગ જયદીપ.
Yeah, good evening, Dr. Yignesh.
Yeah.
Good evening, sir.
Yeah, good evening.
Good evening, madam. Jankna, madam.
Good evening.
મને ચેતનભાઈ જોડે વાત કરી લો.
Good evening, everyone. Good evening, Yagnesh bhai.
ગુડ ઇવનિંગ.
Good evening.
Good evening, madam. Jankna, madam.
Good evening, Samir. Good evening. મજામાં?
બસ એકદમ ફાઇન. તમે કેમ છો મેડમ?
બસ fine, 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 fine.
Bhaskar sir is here.
Yes.
દર્શક થોડુંક લાઇટિંગ વધાર, તારો ચહેરો જ નથી દેખાતો.
Hello, good evening.
Good evening, sir.
Yes, good evening, sir.
Good evening.
Good evening, sir.
Good evening, madam.
Good
Nice.
evening, sir.
Good evening, sir. Nice to see all the stalwarts here.
Including
Stalwarts
Dr.
તો આપી
Bhaskar.
હો.
Including Dr. Bhaskar.
Gujarat stalwarts.
Good evening, sir. Raju sir, I guess.
Hello,
Good evening, sir.
everybody.
Good evening,
Raju
sir.
sir.
Good evening.
Dr.
Good
Raju
evening,
sir.
Chetan bhai.
Good evening.
Good evening, everyone.
Good
Good evening,
evening.
sir and ma'am.
Good evening.
I think it's 9, sir. We can start.
Khalatkar sir is joining in 1 minute.
Okay.
Just 1 minute. Just.
My voice is okay?
Audible,
Yes,
sir.
Yes, sir.
Yes,
Clear.
Audible. Yeah.
Okay, fine.
Good evening, sir. How was your trip, sir?
It was excellent. Enjoy it.
Great.
Dashraj bhai still needs some light.
He will throw a significant light later on.
ચાલુ નહીં હોય છે ને
સમીર ભાઈ શરૂ કરાવીશું?
Vasant sir has joined.
અચ્છા,
Vasant
yes,
sir has
okay.
joined.
હા.
Jaydeep has joined. Huh? Jaydeep.
Yeah,
Ah,
Jaydeep, sir.
Yes, sir, join.
Yes.
આવી ગયા, ડોક્ટર.
Good evening, all. Good evening.
Good evening.
Good
Good
evening,
evening,
sir.
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 Good evening.
Good evening, Vasant ji. Good evening.
Good evening. Good evening, Bhaskar. Chairman Saab, good evening.
Good evening, sir.
President Sahab.
President, sir. Good evening.
Hi, Neha.
Yes, Anjika madam. We can
Hello,
start
sir.
now.
Yes, sir.
Yeah, we can start.
Good evening to everyone. A very warm welcome on behalf of Academy of Pediatrics Gujarat for today's session of Expert Connect. Welcome to all the esteemed dignitaries who are with us today, seniors, colleagues and friends. Today's episode of Expert Connect is in association with the Pediatric Infectious Disease chapter. So common issues, infections in office practice will be discussed. It's going to be a case-based discussion and how to manage the patients and when to refer. So before we start all the session, I would like to welcome Dr. Jagdish Khamar sir, the President of AOP Gujarat, for giving his welcome address.
Good evening to all. On behalf of AOP Gujarat, I welcome you for the webinar series that is Expert Connect. I welcome firstly our President, Dr. Vasant Kalatkar, PIDA Secretary, Dr. Chetan Bhai, experts of this evening, Dr. Raju SHAH sir, Dr. BHASKAR sir, Dr. JAYDEEP sir, and my moderators, friends, for this evening, Dr. DARSHAK sir, Dr. NEHA, Dr. RATNA, AOP MEHSANA, and Dr. SAMIR sir. This webinar series is brainchild of our Secretary, Dr. AOP Secretary, Dr. Samir Bhai, and a float and AOP as a AOPG Presidential Action Plan. AOPG webinar series Expert Connect is a case-based discussion associated with PIDA Gujarat unit. I also appreciate our overwhelming response of last webinar series by adolescents group. welcome you all once again and request to start the webinar.
Thank you very much, sir. It is our honor to welcome the President of Central IAP, Dr. Vasant Khalatkar, sir. I request him to say a few words.
Yeah, good afternoon, good evening all. So actually I am in same mood because since afternoon I am attending meetings, that's why I am in same mood. So I bring greetings from IAP. Respected all, Dr. Jagdish Khamman, Dr. Sangvi,
Yes.
Dr. Tushar, Dr. Samir, Dr. Swati, Agnesh is there. Yeah, especially our chairperson of PIDA chapter, Dr. BHASKAR SHENOY, Secretary Dr. Chetan Trivedi, Dr. Samir Thakur, respected past president Dr. Raju Shah, sir. Sir, namaste. It's really pride that you are attending this meeting. Dr. Agnesh, who is very much instrumental for copyship book. Our Dr. Samir Shah, Dr. Darshak. I bring greetings from Central IAP. I saw Dr. JAYDEEP is also there, Dr. Palak, and Dr. Janka. So, Dr. Neha, I said as hello to you. And especially you called me, I couldn't say no because ID and me, it's a different combination. I can't live without ID. Though I know being a president of a central IAP, I'm little bit giving the less concentration. That's I think 25% to ID. But I'm really helpless and I really want to say sorry to my ID friends, all ID friends, my family, basically my family. To say तो घर के लोगों को माफ किया जाता है, घर के लोगों ने ऐसे बोला जाता है. So let's please forgive me for that my absenteeism in ID chapters, so many programs. Next year इसका कमी भर दूंगा पूरा. So really, and this year it's really full of academic. When Bhaskar is there, Chetan is there, so it's going to happen. It was expected also. With Bhaskar was the secretary for me, I know most of the all academics thing he was doing. Thank you, Bhaskar, for that those years, all those conference and everything we had done those days, including ISTP. Really great. And when it's a really great thing that Gujarat is having all the person flooded with ID. Starting with the Dr. Raju Shah. I know the Raju Shah sir as the ID man since beginning. After he became a president. But really, thank you, sir, for your all guidance. Really, Dr. Digant, Dr. Raju Shah, they are really guide for me. I will say they both are the guide for who tempted me to develop an interest in ID chapter. And of course, our friend like Dr. Agnesh, Dr. Swati, and you all. So, and coming to Gujarat, I know that in academics, that to be in ID, really, it's a great work is going on. After that, definitely Adosai chapter also. But Gujarat is not reached by everything. I'd say all humans, all my friends, they are reached by heart. That is very important. Kabhi bhi jao, we are getting the warm welcome by you. Really, I adore that your welcome style always. And everybody says, "Arey Vasant bhai." Nobody says like that. That shows the affinity. एकदम clear, pretty. We very get अपने अपने से लगते हैं. महाराष्ट्र एंड गुजरात इज नॉट डिफरेंट, बट गुजरात आने के बाद ऐसा लगता है कि मैं सही में मेरे घर में आया. मैं किसी के अभी I whosoever now here present ना, I am confident that किसी के भी घर में जाके मैं I can have a lunch, dinner, everything. हक से बोल सकता कि आज मेरे को खाना खाना. That's my friendship with all Gujarat people. And really, this is the excellent project you are doing, that CME with a different chapter. Samir Shah, congratulations for that. Khaman sir, you all are doing a really great job for academic. And automatically, this is we are going for a community also. When you spread the message through this, we are definitely working 24/7. That's for our children, our little kids. That's ultimately to community. So By all these, we always serve for our children, community, and our colleagues. That's our theme for this year, 2025. And I once again want to thank you for helping me in this bid. For your interesting thing, I'm telling you, we have planned one conference at Budapest that is in can you mute Dr. Nidhi? Who is there?
Yes,
सर
yes,
हो गया
yes.
हो गया हो गया सर.
Yeah. So this year, some different mode we are going, that we are organizing one international conference in association with American Academy of Pediatric Emergency, that is at Budapest. This is for your information I am telling. Budapest, and that to be pediatric, and they have accepted our registration only in $200, which is actually $700 for IIP. To make an association, they have accepted in the $200, and the dates will be 15th, 16th, 17th, and 18th of August this year. The most important thing is that they are having a acceptance of free paper, free posters, and oral presentation also, and some topics. If you come with the short topics of 15 minutes or panel discussion of 30 minutes, they are ready to accept, and everyone, those who are going to present paper or poster or topic, they will get a certificate of a faculty of international faculty presenting in a American Academy of Pediatric Emergency Medicine. So I welcome you all there. You will get the brochure there. Within 2-3 days, you will get the brochure. Please get registered there only. And I welcome you all for our national conference of IDJAP also. Thank you once again for giving me chance and calling me. I declare that this webinar got open. Thank you.
Thank you very much, sir, for your words of appreciation. It is our honor to have you here today. In spite of your very hectic and busy schedule, you have joined us. So thank you very much, sir. Now I would like to request Dr. Bhaskar Shenoy, sir, the chairperson of PIDA 2025, to say a few words of appreciation, sir.
Thank you, madam. The respected seniors, Dr. Rajusha and all the seniors, my friends, and Dr. Vasant Kalatkar, who was my chairperson, and I worked as secretary under him, and it was a unique, nice period that I underwent. So having said that, it is always a pleasure to interact with the state of Gujarat, because more than anything, the academics and other things, Gujarat has given the highest number of chairpersons to ID chapter. That is one thing. And all the well-known academicians and chairpersons, they hail from Gujarat. So that is one thing I always held Gujarat as at the highest level. And thank you for inviting me today. And it's a very good opportunity to interact with all of you. And it's a little different kind of pattern that you have made, which is very useful for practicing pediatricians, wherein it's like how the child comes to you and then how do you manage, or how do you arrive at a conclusion, or how do you arrive at a diagnosis? What are the investigations you do? That's how we do it in the office practice. And that is a very good initiative that I liked it. And thank you for inviting me. Thank you for giving me an opportunity to speak few words. Thank you so much.
Thank you so much, sir, for your words and blessings. Now I'd like to request Dr. Chetan Trivedi, sir. He's the Secretary of Pediatric Infectious Disease Academy 25, to say a few words.
Thank you, Dr. Angelica. Thank you, AOP Gujarat, for this wonderful opportunity to be here and making the PIDA part of it. And we know that infectious disease cannot be kept away from all the pediatricians, and that's why this is the Expert Connect. Such a wonderful name it has been, and it is worth it, because here we have a connection of all the experts with the people who have been expert in the field, as well as those who are youngsters. They really are having, full of knowledge, but they don't get opportunity to perform at a big scale. This will be a wonderful hand-holding by seniors and most respected people in the field of infectious diseases like Dr. Raju sir, Dr. Jaydeep, Dr. Bhaskar Shenoy, And definitely the middleman, that connecting person, Dr. Manish, who is going to present this particular case, is going to be very useful. And I would like to congratulate Team AOP Gujarat, led by Dr. Khamar, and a wonderful concept, Dr. Samir, who is a secretary. I know he's a dynamic secretary, is thinking beyond the box. And that's why this conception of Expert Connect has come. So I wish all the success and to this program and webinar series. And I would love to attend the whole session eagerly. So thank you so much for this opportunity and all the very best for this webinar series. Thank you.
Thank you very much, Dr. Chetan Bhai, for your blessings and appreciation. Now I'd like to request Dr. Yagnesh Popat sir. He is the chairperson of Gujarat chapter of PIDA to say a few words.
Good evening all. Respected Dr. Vasant, President, National IAP, Dr. Bhaskar SHENOY, PIDA Chairperson, Dr. Chetan Trivedi, Secretary PIDA, Dr. Khamar, President AOP Gujarat, and Dr. Samir, Secretary. My respected seniors, Dr. RAJU, SHAH, Dr. JAYDEEP, and my dear colleagues. It has been a great opportunity for an infectious disease to again come in front of you with the excellent case-based discussion. And I must congratulate the AOP President, AOP Gujarat President, Dr. Khamar, and Dr. Samir for this novel idea where the young brigade is taking up the challenge of facing the cases under the guidance of seniors like Dr. Raju Shah, Dr. Jaydeep, and Dr. Bhaskar. So we will have a case-based discussion, and let us start the ball rolling with under the guidance of all these experts. Over to Dr. Angelika. Thank you.
Thank you very much, sir. And I'd like to request the Secretary of AOP Gujarat, whose brainchild is this webinar series, Dr. Samir Bhai, to say the vote of thanks.
Respected senior, our President, Dr. Vasant Khaladkar, sir, Chairperson of the PIDA, Dr. Bhaskar SHENOY, sir, Secretary PIDA, Dr. Chetan, Chairperson of the PIDA Gujarat chapter, Dr. Yagnesh Popat, sir, all the other dignitaries, including Dr. Raju Shah, sir, Dr. Jaydeep Choudhury, sir. Thanks a lot for the remaining present and accepting our invitation to become the part of this today's webinar series. My sincere thanks to the each and every participants of the faculty group, that is the panelists, starting from the Dr. Samir THAKRAR, Dr. NEHA PATEL, Dr. RATNA BHOJAK, and Dr. DARSHAK to become the part of this excellent moderating team led by Dr. MANISH MEHTA, who is going to lead today for the whole session. All the participants without which this is the we are not able to conduct in a successive way. So all the participants who are going to remain throughout the journey of today's presentation, my sincere thanks to all of them on behalf of the AOP Gujarat. And last but not the least, my sincere thanks to our President, Dr. Jagdish Khamar sir, and all the EB members of the AOP Gujarat to lead this webinar series in a successive way. And this is the second in a row we are able to conduct. And next month we are planning with a neurology chapter, same pattern with the case-based discussion. That is our main aim and objective. That ultimately, that what we really want to do in our OPD base. Last but not the least, my sincere thanks to the two MOCs of today's webinar series, Dr. Angelika Mehta and Dr. Tejas Hapani, for a successful expecting conduction without any interference. So thanks once a lot, and over to Angelika.
Thank you very much, sir. Thanks to all the experts, especially Dr. Raju Shah sir, who has spared his time today, Dr. Bhaskar SHENOY sir, and Dr. Jaydeep Choudhury sir for being part of this webinar, and I'm sure we have a lot to learn from them. So now, without much ado, I'm going to hand over the further proceedings to Dr. Tejas Hapani. He'll take over now.
Yes. Hello, I welcome you all for this webinar, and I would like to give a brief introduction of our today's eminent persons. At the outset, we have Dr. Manish Mehta, who is a neonatal and pediatric intensivist. Currently, today, he is our moderator, who will walk through us to the various cases and discussions. He is working currently at Synergy Neonatal Hospital and Cyril Neonatal Hospital. He is an executive board member of Central IAP, and also he is an executive board member of Pediatric Infectious Disease Academy. Welcoming our experts today. The first and foremost expert we have Dr. RAJU, a name which needs no introduction. Vasan Khaletkar sir has appropriately just introduced today him as an ID person, but then he is not only an ID person, he is a versatile person. He has been our past president of the Central IAP. He is a veteran teacher. Many of us might have studied directly or indirectly under him. He has authored more than 20 textbooks in pediatrics and more than 100 articles in various journals. Our next speaker, our next expert is Dr. Jaydeep Choudhury, who is the professor at the Department of Pediatrics, Institute of Child Health, Kolkata. He is the vice president. He was vice president at 2019. He is the chairperson of IAP Infectious Disease chapter, and he has also authored several books, and he is also an editor in some of the textbooks. Welcome, Jaydeep, sir. Another expert we have is Dr. Bhaskar SHENOY from Bangalore. He is the head and of the pediatrics department and chief of the pediatrics infectious disease at Manipal Hospital, Bangalore. Additionally, he also has a fellowship in applied nutrition. So he is a master of nutrition as well as infections. Welcome, sir. I welcome all the experts here. Coming to the panelists for today, we have four panelists. Dr. DARSHAK MAKADIA. Dr. DARSHAK MAKADIA is currently working as a consultant pediatrician at PAL Hospital, Surat. He has a special interest in infectious diseases, rare diseases, and critical care. He has several publications and co-authorships, and as well as he is a master trainer of various programs like Advanced Cardiac Life Support, Advanced Life Support, Neural Resuscitation Program, and many on. We have another faculty today, that is Dr. NEHA Patel, who is from Vadodara. She has done her post-graduation and she has done her further training at Mumbai. She has a special interest in infectious disease, especially in bone marrow or solid organ transplantations and infectious diseases in immunocompromised hosts. She also has authored various books and has been a author of a Fungal India Registry. People like me would wonder कि ऐसा भी कुछ होता है Fungal India Registry, but then yes, she is the author of this. Our next panelist is from Rajkot, Dr. SAMIR THAKRAR, a veteran pediatrician and a person who is now into the silver jubilee of his prior practice at Rajkot, the owner of Muskan Hospital and the director of Amruta Hospital. He has a vast experience in holding various conferences at state level as well as zonal level CMEs. He is a trainer for NSSK, and one important feather in his cap is actively involved in the TRUMS project. The TRUMS project is specialized for training of the untrained nursing staff people. He is the vice president and he has also served as the president of AOP Rajkot. Our another panelist is Dr. RATNA BHOJAK, who is a young enthusiastic assistant professor from GMERS Medical College, Vadnagar. She has several publications to her record, and one important here is she has undergone a randomized control trial in bronchiolitis. Randomized control trial is a tough thing, and she has the credit of doing it along in her team. She also has a PSU fellowship on her record. Now, very few ladies I would know that who would have undergone a PSU fellowship. A PSU fellowship is generally considered to be the domain of males, but then she has broken this bar and undergone a PSU fellowship. Now, I think with this, we'll have a smile on Dr. Angelica's face. And with this smile, may I ask Dr. Manish Mehta to proceed for today's discussions and cases. Thank you.
Yeah, thank you, Dr. Tejas, for an excellent introduction of all the experts and the panelists. Today, I'm lucky to be given an opportunity to present a case in front of such an experts like Dr. Bhaskar SHENOY sir, Dr. Raju SHAH sir, and Dr. Jaydeep Choudhury sir. It's feel like those residency days when we are going to present a case in front of our teachers. So it's a great opportunity, and I thank Dr. Jagdish Kamar sir and Dr. Samir Shah sir for giving me this opportunity. And I hope I'll do to the expectations. So without wasting a minute, we'll back to our business. So these are just basic things. The theme of this the webinar is to issues in office practice, how to handle and when to refer. So this is mainly meant for our general pediatricians. So our messages will mainly be directed towards our general pediatric practice only. And I request all the panelists to keep their video on throughout the discussion. And in between, if they want to say something, please raise your hand and you can speak in between. Otherwise, my questions will be targeted to a particular panelist at that time. So approach will be more important than the diagnosis. So purpose of discussion is to how do you approach this patient rather than directly jumping onto the diagnosis. And discussion will be more related to general pediatric practice. So let us start with our first case. This is our routine case in our day-to-day practice. A 6-year-old boy who has a fever for 2 days and there is no cough, cold, diarrhea, or vomiting. So just complaint of fever. I think 30% of our patient in our OPD practice present like this. So you have Monday morning and busy OPD and you have this 6-year-old child whom you will be able to give maybe 5 to 6 minutes and you have to find out whether what do you want to do with this child. So I'll ask Dr. SAMIR THAKRAR sir. So how will you approach this child with undifferentiated fever?
Good evening, respected seniors, and thank you AOP Gujarat and PIDA for inviting me for this panel discussion. Thank you, Manish bhai. Presently, we are looking into a case of 6-year-old with fever for 2 days, and there are no associated complaint of cough, cold, diarrhea, or vomiting. So first and foremost thing, I would like to know the pattern of the fever, what temperature is being recorded or not, and whether the interfebrile period of the fever, when how the child is behaving, and is there any associated complaints like headache or odynophagia, maybe burning maculation, and is there any similar history of illness in the family as well, if anybody else is suffering, like maybe a viral infection or something like that, and is there any recent travel history? Plus, my history wouldn't be complete without knowing the immunization status of the kid at this age, whether his immunization about all the infectious disease has been taken care of. And definitely the red flag symptoms, we would like to screen the patient for, whether he's lethargic, he is reacting, his intake, he would like to know about his intake, his diet, and urine output, etc.
Yeah, that's fantastic. So he has covered almost everything. So within 5 minutes, you will try to know whether first you need to treat this child on OPD base or you need to make this child hospitalized. So that will be decided on the base of red flag symptoms. And after that, you want to decide whether you want to investigate this child or you want to wait. And after that, you want to decide whether you want to give antibiotics or you have to just wait. So this child has only fever, no other symptoms, no family history of any other symptom. And fever is somewhat low to moderate grade, around intensity of 100 to 101, and subsiding with paracetamol. But again, after 4 to 6 hours, it is recurring. But there are no other symptoms. Child is stable and no vomiting or abdominal pain or no other symptoms are there. So now it's 10. The child went to some general practitioner in between. After 2 days of showing to you, child has persistent fever, so went to some general practitioner. He did some basic investigation over there. And in those investigations, CBC was normal, but typhoid IgM, which is a fancy investigation nowadays, so it is positive on day 4. And there is high fever persistent with increased intensity since last 4 days. Oral intake is somewhat reduced. There is vomiting, child is lethargic, and child has been given cefixime on the base of very enteric fever at the dose of 10 milligram per kilogram per day since last 4 days by the general practitioner. Now, still child is having persistent fever, getting lethargic, so child is coming back to you. So I'll ask to Dr. Ratna. So what is the interpretation of the typhoid IgM? Like, what will you do on this base? And any further investigation you would like to do for this child, or you want to start any treatment at this stage?
So typhoid IgM usually it's the screening test that we do before the blood culture gets positive. So one thing is that it has around 80 to 85% of sensitivity and specificity. So I would definitely consider it, but I would not rely on it. I would consider that first of all, I first consider whether I'm dealing with enteric or not, because typhoid positive even in dengue, malaria as well as brucellosis. So I would like to see the further investigation for sure. And for that investigation, I would like to know that, and it is a 10th day of fever. So I would like to do the repeat CBC. Then what is the status and how is the CBC going towards? So CBC, CRP, I would definitely go for. I would like to know the blood cultures as well as the urine routine and everything. That if I'm suspecting, and it's 10th day of fever, I'm already partially treating it with cefixime. So, and still the fever is persistent. So I would first consider whether I'm dealing with insect or not. Second, I would like whether I'm dealing with some complication of typhoid or not, because I'm at least partially treating it. So for that, I would like USG, X-ray, and the repeat even SGPT, because hepatitis is more commonly in typhoid. And yeah, that is the first those investigation I would like to know. And I would like to add on the blood culture, that if stent they partially treating and having typhoid, whether I'm dealing with typhoid confirmatory, and if suppose I'm dealing with typhoid, whether it is a resistant variety or no, because South Asia recently is facing many resistant cases of typhoid. So this is what I would plan as per the management.
So would you like to hospitalize this child or you would treat on OPD base?
Sir, we have already given an OPD basis. 4 days we have given treatment. So I would like to hospitalize this child and give a proper set trials on and send all the investigation, and then later on see the post how it's going further.
Yes, fine. So it's rightly said. Typhoid IgM, it's not the test to be completely discarded. It's like it has high negative predictive value. So if it is negative, almost with 90% confidence, you can say this patient may not have enteric. But it doesn't have very good positive predictive value. So it is around 50 to 60% of positive predictive value. Because as Madam has said, there are few cases in which typhoid will be positive, IgM will be positive in spite of not having enteric fever. So positive typhoid IgM, we have to take it with a pinch of salt. But negative, definitely we can somewhat say this child probably will not have enteric. So these are the basic investigation that has been done. Hemoglobin around the range of 9, WBC count on the lower side. In differential count, so initially polymorphic, and platelet count downgoing. SGPT a bit high, transaminase bit high, 90. Serum Vidal was done, that was 1:160. Typhoid IgM, as I said, was positive, and bacterial blood culture was sent. So, Dr. Darshak, now you are sure this is enteric or still there is some dilemma in the diagnosis?
Thank you, AOP Gujarat, PIDA chapter, Jagdish sir, Samir sir, and Manish bhai for giving me this opportunity. Regarding this case, the counts, if we see, it is more look like there is a cytopenia. Like in the 26/9 second report, HB is dropping, WBC count is dropping, with that platelet is also dropping, and SGPT is slightly on higher side. So if we see the history, the 10 days fever is there, and from last 4 days, the fever spike is increasing. So classical history-wise step-ladder pattern fever is here. Second thing, supportive diagnostics. Supportive-wise, if we see the WBC, there is a dictum in medical college, like all bacterial infection will have leukocytosis, except enteric fever, where we can see the leukopenia. So here we can see here leukopenia is there. Second thing, there is relative lymphopenia is also there. And if we see the eosinophil, then in first report it is just 1, and in second report it is 0. So there is relatively eosinopenia is there. These are the characteristic with the CBC with the typhoid fever. Supportive wise, typhoid and Vidal is also done here, though it is positive, but we will not consider it. Main thing is the carry home message here is blood culture, and blood culture. Blood culture is a gold standard diagnostic test for the typhoid fever. It is the most important investigation. It has sensitivities for 40 to almost 90%. The yield is high in the first week, and on the 4th week also it is around 40% is there. So I will consider this as enteric here, and second possibility should be the viral fever. There is diagnostic dilemma. What I will emphasize here is regarding blood culture. So blood culture, there is a 0.3 colony forming unit per ml of bacteria is required to grow the culture. So optimum volume will be around 5 to 10 ml in the blood culture. So the ratio of blood culture growth to blood should be maintained around 1:5. So it will grow the culture. That is the only mistake we are doing. Serology wise, Vidal and typhoid is there, but they are non-specific. So there is no point of discussion is here.
Yes, perfectly. So the most important thing is how the blood culture has been collected. So people say that blood culture is only 65 to 70% sensitivity, but I will say if it is properly collected in untreated enteric fever, definitely it should have more than 90% of sensitivity, because it is one of the most easily cultivable organisms, Salmonella typhi. So this is confirmed now. We are treating probably as a case of enteric fever. We have taken blood culture. We have started ceftriaxone with a dose of 100 milligram per kilogram per day. Chest X-ray was normal. Sonography was done. That was hepatosplenomegaly with mild ascites. But on day 5, child is admitted. Your sister, your medical officer is complaining, sir, fever to abhi bhi aa raha hai. Child is not improving. We should do something. We should change some antibiotic. Whether we should add azithromycin, add fluoroquinolone, or we should change to meropenem. Whether we are dealing with MDR or XTR typhoid, or we should continue with the same. So we have Dr. Neha Patel, who is ID expert. I'll ask Madam Madam, what we are dealing with? This is day 5, fever is persistent.
So as per the clinical progress till now, enteric fever clinically would take time after we start proper ceftriaxone 100 mg per kg per day. So I would like to see that fever pattern. If it is spacing out and the spike intensity is decreasing, then we have to counsel parents and even other people that the typhoid fever will take time. Now, another question is fluoroquinolones. So fluoroquinolones is a very good drug. It has a very good intracellular penetration. It has a very good biliary penetration. So initially it was the drug of choice. But nowadays we are seeing for last 10 years, fluoroquinolones resistance has increased. So now it is not routinely recommended empiric therapy for the enteric fever. So we have fluoroquinolone resistance. So, and when we add azithromycin, so ceftriaxone, cephalosporins, they take time for the longer defervescence of fever. So we don't have clinical trial of comparing ceftriaxone plus azithromycin and only ceftriaxone study. That is only the only difference is the defervescence will take a shorter time with the combination, but that doesn't mean we should add azithromycin. So we should continue ceftriaxone, and in other places where there is a ESBL strain of Salmonella typhi, which is resistant to ceftriaxone. In that condition, clinician should take a call. If child is sick looking, not doing well, only on ceftriaxone, then they might add azithromycin, but not on routine basis. Yes.
So this is well said. So most important thing is only fever is not the criteria when child is not responding. You have to see your fever spikes, whether they are reducing, the gap between the fever intensity is decreasing, general well-being of the child is improved, diet appetite has to be checked whether it has improved or not. So probably these things, if you inquire in detail, these things will show some improvement on the 5th, 6th day. Fever sometimes go away by 7 to 8 days in spite of giving ceftriaxone sensitive antibiotic. So no question of giving fluoroquinolone at all, as madam has said. Sometimes in conventional culture, we see in disc diffusion, we see ciprofloxacin sensitivity. But in spite of that showing that sensitivity, the MIC is so high for ciprofloxacin in enteric that we should not use, because chances of resistance and relapse will be very high if you treat with the ciprofloxacin. So nowadays they consider naltrexone as a surrogate marker for fluoroquinolone resistance, and recently a few labs have started doing payfloxacin sensitivity, which is considered as a perfect surrogate marker for the fluoroquinolone resistance. So if payfloxacin is resistant, that means fluoroquinolones are resistant. So we consider XDR typhoid only if there is ceftriaxone and azithromycin resistant. Otherwise, in MDR, we all know three drugs, ceftriaxone and fluoroquinolones are resistant. And in MDR typhoid, we consider all three amoxicillin group of drugs, your chloramphenicol and cotrimoxazole. These three group of drugs are resistant, then we consider MDR. So probably there is no meaning of using MDR nowadays, because we are not going to use these three drugs at all for enteric fever. And nowadays, fluoroquinolones also we are not going to use. In spite of showing sometimes sensitivity in the culture sensitivity, we are not going to use fluoroquinolones. And adding fluoroquinolones, people like to give ceftriaxone with ofloxacin or levofloxacin, is of no use. So please avoid that. Just use single drug ceftriaxone and just wait for at least 7 to 8 days. Just see the general well-being of the child, appetite and everything. Probably in 99% case, you will see improvement by the age of the date of 6 to 7 days of illness. So now I request Dr. Jaydeep Choudhury, sir, who is with us. We had discussed this case in Pedicon also. So, sir, please give your expert comments regarding this case.
Yeah, good evening, everybody. I think everything about typhoid fever has been discussed. So there is hardly any scope. The typhoid remains an enigma actually, because it's mainly presents without focus, and there are a lot of atypical presentation, and hardly there is any telltale signs that we can get in a typhoid fever, because hepatomegaly and all that, most of the time it's not that certain as the cause of typhoid fever. Regarding investigation, one thing I would like to add is that, see here the typhi dot was done on day 4 of fever, but typhi dot is basically a serological test. So probably typhi dot in the first week may not be that yielding, just like Vidal. And of course, it has been discussed already that though the sensitivity is quite wide, and also the specificity, and in an endemic country like us, the typhi diet is a questionable investigation. So of course we cannot rely too much on typhoid. Blood culture, yes, there are some limitations. In the routine blood test, one thing rules out typhoid almost, like if there is leukocytosis along with eosinophilia, high eosinophil count, that rules out typhoid absolutely, more or less, not absolutely, more or less, because if there is leukocytosis along with eosinophilia, then typhoid is unlikely. Of course, there are limitations of blood culture that we know, and culture of other body fluids they have limitations. Talking about management, as you have already told, number one, typhoid should be treated by monotherapy. There is no question of combination, and fluoroquinolones is nowadays not the drug of choice due to the increasing MIC and other factors. Of course, orally cefixime is the drug, definitely, and in this case, it was started at 10 milligram per kg. But ideally, cefixime should be started at 20 milligram per kg. The criteria for admitting a child is if the child is very sick, unable to take orally, there is question of maintaining hydration, then definitely this child needs admission. Other than that, there is not much difference in oral cefixime or IV ceftriaxone. So there is no question of polytherapy. It is cefixime, and if after starting cefixime, the clinical improvement should come within 72 hours. If there is no clinical improvement, if the child is not feeling better, then there is a cause of concern, because defervescence can take 8 to 10 days even. Now, whether to go for azithromycin, that's a quite controversial issue. There is no question of adding azithromycin. If the child is not feeling better, because see, proving MDR typhoid is easier said than done, because blood culture often doesn't come positive due to prior antibiotic therapy and so many other factors. So if the child is not recovering even after 5 days of oral cefixime, not only fever, but the general condition, then there is a scope of azithromycin at 20 milligram per kg per day. And other than that, there is no question of addition. Now, if the child has to be admitted, then of course, if the child is not responding, then the second line drug is probably the meropenem. But again, going for a BL-BLI combination is not at all justified, like ceftriaxone, tazobactam, and all that, because the resistance of salmonella is mainly by plasmid mediated and or chromosomal. It's not by enzyme production. So these are irrational. Number one, it should be monotherapy. Number one, no scope for BL-BLI combination. Amikacin should not be used for treatment of enteric fever. And proper dose, like cefixime 20 per kg, ceftriaxone 100 per kg, azithromycin 20 per kg. All said and done, typhoid is still an enigma. And when we are in an endemic country, so we do face hurdles, and we have to go on treating like this. Thank you for a nice discussion. I think everything has been discussed by the experts already. Thank you so much.
Thank you very much, sir, for your expert comments, and thank you for joining us in spite of you having some other commitments around 10 o'clock. So thank you very much, sir. Yeah, thank you, sir. So we'll move on to our next case. That is a 2-year-old boy, high-grade fever for 5 days. There is cough cold since last 5 days and respiratory distress since last 1 day. SpO2 on room air is 94% and respiratory is around 52 per minute. So I'll start with Dr. Samir. So what do you think this child is having, sir?
Yeah, from the history, the child, a 2-year-old boy with 5 days history of fever and respiratory distress since 1 day, with maintaining SpO2 at 94% in room air. So this would be a severe acute respiratory infection with mild respiratory distress, I would say.
Yeah, so WHO
need further
definition
investigation to confirm the etiological part and other things.
Yes, so WHO definition wise, this fits into pneumonia, fever, cough, and breathlessness.
Yes.
So these are the reports. WBC is 18,000, neutrophilia, hemoglobin 10.59, platelet count 1.8 lakh, CRP 84, and this is the X-ray. Now, What do you think?
Yeah, the count 18,000 and CRP of 84 with X-ray showing right mid-zone consolidation. I would label this as a lobar pneumonia. And the etiological agent mostly looks like bacterial infection, could be pneumococcal, could be H influenza, maybe staph or Klebsiella as well. But we cannot rule out viral infection in this era when we are getting more and more viral infection nowadays because of immunization coverage of pneumococcal and H influenza and all. So viral pneumonia, lobar pneumonia would be a possibility as well, like influenza virus, para-influenza virus, rhinovirus, adenovirus, or there could be other agents as well.
Yes, definitely. And one more thing, though age is not fitting, classical lobar pneumonia is there, but mycoplasma nowadays also should be kept in mind if child doesn't
Exactly, yes.
respond to your routine antibiotic by third or fourth day.
Yes.
So child was required admission. Now I'll ask Dr. Darshak, what will you start in this child? Will you give oxygen to this child?
First of all, we will admit the child in PICU because child has the respiratory distress. And according to our pulse guideline, if saturation is less than 94, we will go to start oxygen. But here child is in distress, so we can start the oxygen in case of severe distress or shock. Then antibiotics. Yes, so I would like to third generation cephalosporin, ceftriaxone 100 milligram per kg per day per dose as an antibiotic. And as many part of the country, we are seeing the many cases of mycoplasma, atypical mycoplasma pneumonia. So we will like to add azithro 10 mg per kg per dose.
So at this stage, straight away, you would like to start azithro, or you will like to wait?
Sir, as child has already deteriorated, I think I should start here in this case. And if report is negative, we can gradually wean off or stop the antibiotic.
Fine. And any further investigation, investigation or antiviral you want to give?
Yes, sir. The child has distress, so I would like to the blood gas analysis to see the hypoxia and PO2 status. Then I would like to do the PCT and CRP monitoring for the response and how the disease is progressing. As mycoplasma epidemic is going on, then next is the mycoplasma IgM ELISA test to rule out the mycoplasma. And newer test, if patient is affordable, then we should go for the respiratory panel biofire, possible from the BAL, lower respiratory tract sample.
Any other panelists want to differ or want to add or anything?
So considering the age, I would put mycoplasma on a lower on cards because 2 years old with this pneumonia, so more likely viral and other common community acquired bacterial etiology.
Yeah, so what pneumonia study says ki, if your child is having pneumonia on X-ray, whether you consider it is a viral or bacterial, you should always initially start antibiotic, one thing. So here the drug of choice will be either amoxiclav or ceftriaxone. That will be the first drug of choice. Probably for adding azithromycin, I think we will wait because this child has just come to us. We can just wait for 48 hours because child is though having distress, but is not that critical or requiring ventilatory care. So probably at this stage, we'll start with the one single drug antibiotic, either ceftriaxone or amoxiclav. Antiviral, though child has history of cough, cold, but the X-ray picture is not classical of any viral pneumonia. So probably at this stage, we may not start any antiviral. An investigation, as Dr. Darshak has said, maybe child is critical in ICU, so will require blood gas, though culture yield is less in invasive pneumococcal disease, but still, for the safer side, we will always take blood culture whenever we are starting antibiotic. So that will be additional thing. At this stage, probably will not think of giving any like PCR or any other test because we have just started the treatment. Like when will you, Dr. Darshak, when will you expect this child to improve if you have started antibiotic?
So generally within 48 hours, you will see the response. Like hypoxia will come down, the cough and fever pattern will be settled down.
Yes, so that is 48 to 72 hours is the ideal time when pneumonia should start responding to your antibiotic. Now, this child has some different course. Child was admitted at nursing home for 3 days. IV amoxiclav was started for 2 days, but the distress has increased and referred to ICU for further management. On admission, child was having gasping respiration, severe mixed acidosis. Child was hypoxic, hypotensive. Child was straight away kept on ventilator. Meropenem and vancomycin started. And this was the X-ray picture, almost right lung, almost completely hazy. So Now I'll ask Dr. Ratna, are these antibiotics fine? You want to have some other idea or anything else you want to add at this stage?
So in this case, as it is asked at initial choice, I would like to comment that initial choice was very stable because at 2 years, as we said, that we suspect that streptococcal pneumonia is most common cause, and as well as staphylococcus and the viral pneumonias or the atypical are more common. So fairly co-amoxiclav or ceftriaxone or third generation ceftriaxone would be fine in this. Now the second cause or the second X-ray that was showing, because initial my in head it was going, since it was a consolidated lesion and initial phase, I thought it was a bacterial thing. But the way it is rapidly progressing within 2 days. So first I would suspect that there is a rapid progression. So if it's bacteria, if it's a bacteria, then it can be a staphylococcus, and that also rapidly progressing one. And for that, definitely I would like to add vancomycin or linezolid in it, either of the choice. And second thing would be rapidly progressing, since all the whole of the right lung is involved. It can be Klebsiella or Pseudomonas also. So that, considering the bacterial pneumonia, meropenem and vancomycin, I would say it is the right choice. And second thing I would do, I'll have a panel in mind. If it's just not antibiotics and I have to comment on investigation, I would definitely consider panel in this, because the way rapidly it is progressing, we will have to have a suspect on viral pneumonias also, because the rapid progression, because initially it was bacterial localized, now it's rapidly progressing. So we need to know what we are dealing with.
So you will do any further test in this child now?
Sir, I would like to have respiratory panel definitely now in this case now.
Yeah, so now you have intubated child on ventilator, so probably BAL will be easy to collect. So this is a good time to send BAL, and somehow BAL yields adenovirus. Now I asked Dr. Neha, this is now adenovirus. What will you do with the antibiotics? Is it only adenovirus or something else?
The presentation goes on that initially lobar pneumonia on broad spectrum antibiotic and now worsen, and now we have a diagnosis. It's a microbiological diagnosis, the adenovirus in BAL. So it is a good BAL PCR has a good sensitivity and specificity. And as we are saying that adenoviral pneumonia are presenting like this, they have a presentation like bacterial pneumonia. They have a lobar consolidation, which is atypical presentation, as we say viral presentation, and they have high counts, they have neutrophilic predominance, even they have high CRP. So this fits in with adenovirus and with the severity. So there is severe adenoviral pneumonia. And usually and once we have the diagnosis, we should stop antibiotics, because we don't have any other things. We have gram stain was also negative. And sir, I would just want to comment on the escalation of antibiotics. So from ceftriaxone, after the rapidly deterioration, to change over to meropenem and vanco, I would differ here that community acquired infections, they are sensitive to cephalosporins, and when we are thinking of hospital acquired, we would go to carbapenems. But I would suggest to restrict to cephalosporin and think of other differential, and adding vancomycin is correct to cover MRSA. So when we should consider viral pneumonia, so this was a atypical presentation. Usually viral pneumonia have a viral prodrome, and there is a seasonal spurge. There is a family history of similar illness in the family members, and they have a more of a dry cough, not more of a wet cough or sputum. And the usual viruses are like influenza, RSV will have a more of a upper respiratory tract infection. Then rhino and RSV can cause bronchiolitis in infants and even up to 2-3 years of age. Parainfluenza viruses, human metapneumoviruses. And can adenovirus pneumonia be so severe? Yes, that can be very severe. And even there is one Eastern India study. They done study of 95 patients with adenoviral infection. Out of them, 33 had a severe adenoviral pneumonia, and out of them, 27 died without the specific treatment of that. So mortality is also high with this adenoviral pneumonia. And when we have a diagnosis, we should follow antimicrobial stewardship, and we should stop antibiotics after this many days. Yes.
So if your child is still on ventilator, childless settings are high, and adenovirus is isolated, still you would like to stop your antibiotic at this stage, or you would like to wait?
So, sir, as I had encountered 6 adenoviral pneumonia patients in last 2 years, and they all were a moderate to severe category. And after 10 days of empirical antibiotic and antiviral, if child is not improved and we have adenoviral diagnosis, then, sir, to continue that, I don't find that would help us. You can continue that, but then the definitive management of adenoviral pneumonia is also mandatory. So for once you add adenoviral, like immunoglobulins are a better strategy for this treatment, and very effective, as we had given to our patients as well. And then you might stop after 24 to 48 hours once you see the difference after giving the definitive treatment.
Yes. Dr. Ratna, you wanted something?
So I thought that since it's a very severe case and viruses, usually adenovirus also, there is some immunocompromised state, and considering ventilator also, we can even send blood culture and just wait for the antibiotics. And we can just rule out that blood culture also, and then since viral panel is already ruled out, but we can always take one blood culture and then withdraw the antibiotics. That will be safe in such cases.
Yeah. So
Agreed.
regarding antibiotics,
Yeah.
So regarding antibiotics, we have two views. It's a probably gray zone because child is critical on ventilator. Sometimes we may not be like very confident to stop the antibiotic, but we have isolated adenovirus on PCR, and now retrogradely if we see child has started with cough, cold, and then breathlessness started after the 3rd, 4th day. So probably it looks like viral, but still we have expert for that only. I request Dr. Raju Shah sir to comment on this case, sir.
Well, I very nicely discussed case. And in my practice, what I normally do is on day 1 or 2, when a patient comes with me with the fever, cough, and cold, I always try to give importance to the symptoms. And my learning and teaching is whenever there is a presence of rhinitis, I would first like to rule out viral infections only. In my practice in last 1 year, I must have done viral panel, upper respiratory panel in more than 400 cases. And out of that, I had shown in one of my presentation in our Ahmedabad branch that I had almost 160 cases of viral disease detected, and there were about 12 cases of adenovirus also. And the presentation of this child was like some viral only to begin with. And when you examine such patient in detail, probably you might get some clue like, redness of conjunctiva, some, white follicles or some patches in the throat, which may indicate that there is a presence of some virus, which is like a adenovirus. Yeah, after looking at X-ray, definitely you'll start with the antibiotic, thinking that probably this would be both virus as well as the bacterial infection. The treating with that and follow up, the next X-ray was really very bad, and so child definitely needed PICU admission. But the escalation of antibiotics to meropenem and vancomycin was not correct, because very rightly pointed out that community acquired pneumonia, 2-year-old child and immunocompetent child, chances of getting gram-negative infection is much remote or less. In that place, probably I would consider to continue ceftriaxone, adding vancomycin or probably clindamycin, because there could be a methicillin sensitive step also looking at the picture. So like to continue with that. And once you get the diagnosis of adenovirus, probably yes, you may de-escalate, but at least you don't stop all the antibiotics. You continue with ceftriaxone, just wait and see. And very rightly pointed out that if the child is very serious and not responding like that, probably you'll have to go for IVIG. And in that case also, you'll continue with at least one antibiotic, because we want to protect. We are not sure or 100% sure that there is no bacteria at all. There are in the past studies of the patients died from influenza pneumonia, and in those autopsies also, they had found that almost all of them had pneumococcal infection. In our case, we could have also asked for the history of vaccination. If child has been vaccinated for pneumococcal, probably that again tells us that there is a high chance of non-pneumococcal type of infection. So this is how one can deal with these types of patients. Thank you for excellent input from all the panelists as well as Manish. Your input is also excellent. Thank you very much.
Thank you very much, sir. Thank you very much, sir, for your expert comments. Dr. Bhaskar sir wants to add something.
Yeah, I definitely agree with Dr. Raju and other panelists about the antibiotic escalation and de-escalation. So meropenem is not the choice for these things. So it is the ceftriaxone you should have continued adding along with vancomycin. The other thing is the second X-ray was showing the whole whiteout kind of thing, and this one the angles are blunted. So it is better you get a ultrasound also. See, after that we know that it has resolved, but at that point of time when the fever is persisting, we should see whether there is any complications like empyema or other things. So it is better now. Point of care ultrasound is very good. We can rule out that. That is one thing. The third thing is always the upper respiratory panel may not show all the, I mean, it may give a different organisms because there are some organisms which are normally they habitate in upper respiratory tract. But here it was a lower respiratory tract sample. So that gives more this thing. But we don't have a courage to stop antibiotics in such cases. Second thing is, there are many viral infections. They have a secondary bacterial infection. For example, even with the influenza, crude influenza, the secondary staphylococcal infections are very common. There is a lot of studies and lot of reports about that. So I think antibiotic has to be continued at least one as sir too. Thank you.
Thank you. Thank you very much, sir. So we'll move on to third case now. This is an 8-year-old female child. She's a known case of Down syndrome, trisomy 21, and history of fever since last 5 to 6 days, moderate to high grade without rigors, abdominal pain, severe colicky, poor oral intake, weakness, abdominal fullness, generalized abdominal fullness, occasional vomiting which is non-bilious, and history of long-standing constipation, taking laxatives intermittently. As being a Down syndrome, probably that is the reason for chronic constipation. There is a past history of recurrent fever in last 6 to 7 months, and there are 4 episodes of such illness, and each lasting for 6 to 7 days and treated with OPD base with some antibiotics and symptomatic medicines. Family history, there was no history of any major illness in the family. One healthy sibling of 15 years. Immunization history complete till the age of 2 years, but after that no boosters were given. And birth history, born to non-consanguineous marriage, full-term healthy child, developmental delayed development because of Down syndrome, and dietary history more often the crush food, and so dietary management was not that great. Now I'll ask Dr. Darshak, from the history, what ideas come to your mind? Like, what could be this recurrent illness in last 6 to 7 months, almost 4 to 6 illnesses, it lasting for 6 to 7 days, and known case of Downs with some abdominal distension.
So if you do the dissection of the history here, the child is Down syndrome, has developmental delay, has partial immunization, and history of recurrent illness is there. But there is also history of chronic constipation, which is suggestive of Down syndromes are more prone for the hypothyroidism and the celiac disease. So they can present with generalized abdominal distension, pain in abdomen, and constipation. We should think of this disease in the mind, though they are not induce the infection and fever. For the fever, this part, there may be partially treated. Some bacterial infection can be the first possibility. Second possibility could be the viral as an infection, like HIV or EBV, we should keep in the mind. And in the bacterial, the most common is the enteric. Partially treated enteric can lead to recurrent fever. And sometimes there is a partially treated UTI. Due to the VUR, there is no proper treatment of the UTI. And last not but the least, the chronic disease TB, which is there in our country like India. The second possibility could be the inflammatory disorders. There is a recurrent history is there. So SLE and other things we should keep in mind. And as a child has the recurrent problem, we should think of the malignancy also. because leukemia and lymphoma incidence is almost 10 times higher in this kind of immunocompromised child. So the child has the primary or secondary immunodeficiency. So this could be my differential.
Yes, yes, definitely. And even repeated fever, Down syndrome, chronic constipation, even recurrent UTI could also be one of the possibility there, because of constipation, child is getting recurrent, plus Down syndrome, probably hygienic issue may be there. So these were the investigations. These is the vitals. High grade fever was there. Otherwise, nothing was there. Weight and height below percentile because of the Down syndrome. There are features of Down syndrome. There was pallor, clubbing was there. Some corneal opacity in both the eyes were there. Liver was 3 centimeter palpable. Generalized distension was there, but no free fluid, signs of free fluid were there. And the fecal matter was palpable. By respiratory cardiac system was normal. Neurologically, child was normal. And these were the investigation. Anemia was there. Count was normal, almost platelet count normal, SGPT normal. Urine once showed 10 to 12%, but twice urine culture was one time showing more than 1 lakh colony count, one time showing 70,000. Chest X-ray was normal. And USG abdomen outside done, that was suggested of mild hepatosplenomegaly. Blood culture was negative. Dr. Ratna, what do you think? What do you think at this? Dr. Samir, what do you think at this stage of this investigation?
Yeah, basically we are dealing with a Down syndrome patient who is malnourished, has anemia, has a recurrent infection in past, has chronic constipation, and rightly said by Dr. Darshak that it could be there are chances of recurrent urinary infection because of constipation and other issues. And she has documented E. coli of more than 1 lakh in May 29, and even in July there was significant E. coli. So there are a couple of episodes of UTI in this child. X-ray being normal in this current scenario, USG abdomen, mild hepatosplenomegaly, which could be because of any sort of infection, intra-abdominal infection. It could be because of enteric as well. And blood culture was negative. So this is basically a malnourished child with growth retardation and anemia, with chronic constipation and recurrent episodes of UTI we are dealing with.
Yes, fine. So probably either we are dealing with some recurrent infection or some chronic infection or some infection which has been partially treated. Either of these three things are there, most probably. So this was the further progress. Child was admitted with high fever. Routine investigation were done and started on injection, ceftriaxone and supportive treatment. And these were the reports. Hemoglobin was further down 6.5. Hypochromic microcytic anemia. ESR was very high. SGPT normal. TSH, as rightly said by Dr. Darshak, TSH normal. HIV non-reactive. TTG IgA was done. That was normal. Urine routine micro was done, but culture was showing E. coli 1 lakh colony count. Chest X-ray normal, blood culture was negative, and sonography done that was suggestive of mild to moderate enlarged matted nodes in infraumbilical and RIF region, minimal ascites, and mild hepatomegaly. This was the picture on the sonography. So if you see the summary, child is a known case of Down syndrome, recurrent urinary infection, chronic constipation, undernutrition, severe anemia, hepatomegaly, high ESR, and enlarged matted lymph nodes in the abdomen. Now I'll ask Dr. Neha. What do you think probably this child has now?
So now we have discussed all the possibility from the history and the examination. Now as the child has recurrent UTI, but there is no pyuria, there is bacteriuria, but not frankly fitting in with urinary tract infection. And now we have narrowed down to abdomen. It is more of an abdominal syndrome now. There are ESR is high, and this chronic, ongoing, and recurrent episodes of fever, and enlarged matted lymph node in abdomen. So now we will further narrow down possibilities of enteric, but now the counts are normal, so it is less likely than chronic recurrent infection. Tuberculosis is a possibility with undernutrition. And we would like to further see what is the exact picture in abdomen. Apart from lymph node, any other organ is involved. So further CT abdomen to look for, and if now we have a findings, then probably microbiological diagnosis of the disease we should go further with.
So yeah, so at this stage we'll think of some chronic infection like brucella or maybe tuberculosis. This even brucella could also be a possibility with hepatomegaly and lymphadenopathy. Child is down, so may not say some arthralgia or something may not be there. classically. So those
Agreed.
could be the possibilities. So as rightly said, first possibility will be tuberculosis for us. So what we did was gastric aspirate was sent, that was negative. We planned USG guided lymph node biopsy, but radiologist refused because of multiple additions. When he saw on the sonography, it will be difficult and risky to take lymph node biopsy. It may perforate the bowel. So he was not ready to do the biopsy, and he advised to let us do first CT, and then we'll go ahead with the biopsy if required. Now this was the CT finding. Multiple discrete confluent enhancing non-necrotic lymph nodes were there, and mild to moderate ascites and mild hepatosplenomegaly without any focal lesion in the liver. So he said this is radiologist was very sure that this is a classical case of tuberculosis abdomen, and we can consider as tuberculosis straight away. So Dr. Ratna, would you start now AKT in this child at this stage with this report?
So not just the report, my clinical diagnosis also. Okay, there is a history of chronic constipation, ongoing constipation is there. The child's feeding or nourishment is at stake. So he's already immunocompromised. It's a PEN child. Now we don't know exact history of, there's no history of raw milk or something. But when we go for the further investigation, we know that there's a protein energy malnutrition child with some kind of immunocompromised condition, and the child is having this fever. So the history is acute enough, but there's a chronic constipation. And the ESR is in a rising trend, sir. And in USG also, I got metted lymph nodes. Now in CT also, there's metted lymph nodes, there's adhesions. So in this case, I have clinical as well as 2-3 investigation that are pointing towards AKT. So I think in this, even if it's negative gene expert, I will start AKT and confirm my diagnosis. I will not stop to find the TB microorganisms, but I would initially start AKT in such cases.
Right. So any other panelist has some different opinion at this stage? Will you start AKT, or you will wait for the investigation to come?
I think so clinically, as Dr. Ratna said, we should, on clinical basis, should start empirical AKT and to continue further with the, to get the microbiological histopathological diagnosis.
So, see, basically here child is not critical. Okay, and child is almost in the same state since last 6 months. So probably delaying AKT for 2 or 3 days may not harm the child. So I think what I feel, we'll see what the expert has to say at the end. But I feel from my side that we should wait for the AKT till we get the microbiological isolation. At least we should put all the efforts to have microbiological diagnosis. And after that, if we don't get, probably we may think of starting AKT at this stage. Okay, so this child was referred to pediatric surgeon for laparoscopy guided lymph node biopsy, and laparoscopy was done, but because of adhesions, he could not take lymph node biopsy, but he did aspirate the lymph node. He did take ascitic fluid and take momentum for the biopsy, and all these things were sent for investigation of gene expert, gram stain, AFB, and routine examination. And these were the reports. Ascitic fluid was having lymphocytic picture, high count. There was a gram stain, ZN stain was negative. Now what will you do? Gene expert was also negative at this stage from lymph node aspiration. Now what will you do, Dr. Ratna? Any change?
Sir, I would still stick to my diagnosis that I would definitely start AKT in such cases. But still, I would like to send a culture to find microorganisms or TB, or I would like, when the biopsy is available, I would like to send it for the TrueNet.
Yeah. So one important thing she said is MGIT, that is culture. So nowadays MGIT is available, which report comes in almost 2 weeks time. Previously, our routine conventional culture used to take 4 to 6 weeks to get the report, but now MGIT report comes in 2 weeks. So sometimes we have seen the who are like negative on gene expert and MGIT is coming positive. So that has to be sent, one thing. Which and AKT will start, Dr. Ratna, at this stage? What regime you will follow?
Sir, the initial phase, the HRZD.
Okay, and would you like to give steroids to this side?
So since adhesions are there, I would like to add steroids.
Yeah, so we are suspecting there is some constriction in the bowel. There are some adhesions. So we like to start AKT with steroids. Now, Dr. Neha, tell something about gastric aspirate for AFB.
So, sir, gastric aspirate procedure, you mean to say the procedure how we do?
Yeah, in a short, like.
So, Yes, so we measure the correct length of nasogastric tube. In supine position, we put the child. If the child is small, we restrain using sheet, and we check distance from tip to nose, tip of nose to the tragus, and then tragus to midpoint between xiphi sternum and umbilicus. We lubricate trials tube, gently insert in nose and perpendicular to the face, and we fix with the tap and confirm the gush of air over the epigastrium. And then we aspirate in supine, and then we rotate left and right. And if not getting adequate sample, then we sometimes we have to put 10 ml normal saline slowly without pushing it, and re-aspirate as before, and to contain collect in sterile container. And before removing RT, we pinch and then we slowly remove it.
Do you need to keep child NBM for this?
So we need 6 to 8 hours fasting, and we do in the morning, overnight fasting, and in the morning we do the procedure.
Yeah, so they say at least 3 hours fasting, which is also enough sometimes. And how many samples do you take for gastric aspirate for considering tuberculosis to ruling out tuberculosis?
So, sir, gastric aspirate, we usually take one sample because it is invasive procedure. So we should send an adequate. We should take in 2 sterile container, an adequate amount.
So you also agree with the regime of the AKT and steroid, as Dr. Ratna has said?
Sir, there is no, some study says steroids with AKT as steroid decrease inflammation, but we don't have much of evidence of routine use of steroids with ATT in abdominal TB, because with the treatment also they get healed with fibrosis, and they will come with obstruction. So there is some studies says that will help, but we don't have recommendation using it routinely.
Okay, fine. So this child was started on 4-drug AKT with pyridoxine and steroids. Now, Dr. Samir, how will you monitor this child? This started on 4-drug AKT with steroid. When will you call this child back? When will you expect this child to improve? You are muted, Dr. Samir. You are mute.
Definitely. So we would expect a child in this condition after AKT to improve clinically as well as radiologically, at least after a month. So, considering her clinical condition, we would like to get a first follow-up after a week to check for the compliance about the drugs, and to see any immediate complication happening because of drugs or any other things. But radiologically, I would like to get a repeat expert USG after a month or so. And lab investigation, nothing specific.
Yeah. So to our surprise, things didn't went the way we expected. After 2 weeks follow-up, there was no fever. Appetite was good, but abdominal distension was persistent. Other symptoms were almost there. There was no weight gain, and we checked for the drug dose, drugs adherence, and compliance, and everything. Everything was fine because father, mother were quite educated. Explained to relatives that we have to wait for another 2 weeks because, as Dr. Samir has said, it takes sometimes 1 month for child to show some improvement. So we asked them to wait for another 2 weeks and called them after 2 weeks. And we advise them to do repeat sonography after 2 weeks. Normally, radiological investigation, we don't advise to repeat if child is clinically improved. But if the child has not improved, definitely we'll see for the reports also. So after 4 weeks, there was no weight gain, intermittent fever, abdominal pain again started, appetite decrease, persistent distension was there. Sonography showed almost same finding as before, and there was no improvement. And there was mild hepatomegaly. So, what will you do now, Dr. Neha? What will you do at this stage?
So now, after starting treatment, there is no clinical improvement, and even the radiologically also worsened. So if there is a clinical improvement and if there is a radiological worsening, we think of iris after starting treatment. If there is paradoxical iris response, but here clinically also not doing well. So I would think of now to get, if we get the histopathological diagnosis and again the microbiological diagnosis, if we get a expert or a resistance pattern or a culture, So now we are left with again doing a proper biopsy
Yes,
again
so
of
now we don't have any
representative.
choice. We have to try to get the organism isolated because the trial has not responded. So either we are not dealing with tuberculosis or we are dealing with some MDR tuberculosis. So let us see what report has to say. So we did ultimately the biopsy. Somehow the culture showed Pseudomonas aeruginosa from this lymph node, and gene expert was positive, and that showed rifampicin resistant. Though the yield was low, but it confirmed that there was a rifampicin resistant. So probably we were dealing with the case of MDR-TB. Child was started on piperacillin tazobactam, considering that Pseudomonas just to give it for 5 days. And the child was considered as MDR-TB and referred to the Department of Civil Hospital. They did all the extensive investigation and started of delaminate with background regime for 6 months as an intensive phase. And almost after the 2 years of completion of AKD, child was absolutely fine. The distension was gone, the abdomen was completely normal, and child was gaining weight also. So this was the case of MDR-TB, and this was the regimen just for our reference. But normally, a case of MDR-TB we don't treat at our level only. We have to refer them to the pediatric department. That is the main thing. So there are lots of take-home messages. I think Dr. Bhaskar sir will be the ideal person to tell us what things went wrong in this case and what should we take care when we are taking with a case of tuberculosis. Bhaskar sir.
Yeah, nicely discussed. All the points are well taken. See, the initial presentation of this child, never we imagined that it is tuberculosis. So tuberculosis always mimics anything and everything. So initially, the presentation could have been a routine infection. A child who has had a developmental disability plus history of a proven urinary tract infection is there. So we first think of that. But when some of the reports, some of the times it was not urinary tract infection, we have to see whether this child had infection from, it is a generalized infection, or because this child had some amount of, in addition to fever, some amount of abdominal pain, then vomiting, some pointers to the abdominal system. So with that, even enteric fever, or probably we would have thought of, or brucellosis we would have thought of, or some hidden abscesses, something like a partially treated liver abscess, partially treated subdiaphragmic abscess, and those hidden abscesses also we could have considered. And this child specifically had increasing pallor. So how do you account for the pallor? That is the other question. See, pallor could have been the pre-existing pallor. Probably this repeated infections must have caused more, or there can be some amount of hemolytic status, for example, sickling, and then infection would have increased the sickling, this thing, hemolysis, and then probably he would have gone into the triggered by infection, the anemia would have increased. Otherwise, there is no explanation separately for this. Then third thing is the radiological investigations. Whenever you do an ultrasound, normally we see a lot of mesenteric adenitis and people keep on treating. The question now is, when should I take the mesenteric lymphadenitis seriously? When should I think of something secondary? See, a mesenteric adenitis, which is more than 2.5 centimeters, generally it is said that it is, you should be worrying about. A mesenteric lymph node which is matting, a mesenteric lymph node which is showing necrosis, a mesenteric lymph node which is retroperitoneal has more significance than the this thing. And then if you look at the radiological thing, the corticomedullary differentiation also they will guide. So these are the points that you take it, because just a presence of lymphadenitis doesn't always mean that it is pathological. So you have to look at that. Here, there is a retroperitoneal plus the in the mesentery also there were, and the size was good. I mean, something like 2.4 and 2.6 into something like that. And there was necrosis and matting. Then our antennae should be high. The constipation, whether it is due to the developmental delay or due to this present problem, we are not sure. Probably he had underlying constipation, and this present problem must have aggravated this. And then when you see a necrotic lymph node, don't jump into the conclusion that is always tuberculosis. Tuberculosis is one of the reasons, commonest reason, but not that always we get only the common disease. See, even in a lymphoma, sometimes you can see such pictures and momental thickening. But even Crohn's, see, if you look at the NTEP guidelines, the module, the Crohn's and abdominal tuberculosis always they have a differentiation. So Crohn's is another thing. That's the reason probably they did some investigations. So Crohn's, but the problem, I mean, the differentiation between the tuberculosis and Crohn's and lymphoma and other things, the ascites is more common with the tuberculosis than the Crohn's and other things. That is one thing which, and in Crohn's, the intestinal involvement is more compared to the tuberculosis. So, momental thickening may be there in TB or malignancy, but you have to look at the ascites. Here, ascites was significant. So, features are going more in favor of tuberculosis. And CT enterography, sometimes they do that, and probably that could have been done. And that will help to differentiate between other things when you don't have, till you get into the microbiological diagnosis. The other thing is now the era of interventional radiology, and there are many centers. I think I am lucky to have a center with a very good team of interventional radiologists who, with the CT guided biopsy, in even much more difficult cases than that, which may not be available. But if available, I think probably even a CT guided biopsy would have shortened the illness or shortened the duration of the suffering. We could have started much earlier. And as rightly told, you have to send for a midget. You have to, when the rifampicin resistance is there, then first line and second line resistance tests, you have to do it. And I think rightly they have referred to the government setup who are masters in doing, and we are supposed to send it there. And causes, there was in between, there was when you repeated the ultrasound, it was the size was increasing. Necrosis, as rightly pointed out, it could be one is paradoxical, but whenever you see there is no response, and whenever you see that comparatively it is increasing, one thing is, well, am I dealing with drug resistance? That is first thing you have to think of. Second is my diagnosis right? Am I dealing with only tuberculosis or something else which mimics tuberculosis, or a paradoxical upgrading reaction? And then we have to look at the compliance also, whether the child is taking properly, the dose is adequate. You have to, because I still remember a case which was treated in a medical college with the bone tuberculosis, and they had taken 6 months treatment. There was no this thing, and later it came to our pediatric orthopedician, and then he sent to me for looking at what went wrong. But when I calculated the dose, it was the dose which was wrong, and they kept on giving for months together. When I corrected the dose, till now this child is perfectly fine. What I mean to say is, you have to, in addition to all those things, you have to look at the dose, you have to look at the compliance. These are other important things that we have to do. And as rightly somebody pointed out, starting AKT, probably we could have waited because child is not very ill, child is quite stable. Few days of waiting and getting a proper diagnosis would have made a lot of difference. So this is definitely a case of MDR tuberculosis, which is resistant to rifampicin. So you have to send for, you have to look at the resistance of others, whether it's genotypic or phenotypic, and then start accordingly. Very nicely discussed case. Thank you so much for that.
Thank you very much, sir. You almost revised whole NTP for us. So thank you very much. And the case was taken. The main purpose of this case is that only that just go through NTP guidelines. They have been. Yes, sir. Raju, sir. Please. Sir, your voice is not coming.
Muted, sir.
So can you hear now?
Yes,
yes, sir. Yes.
Yeah. Definitely very, very good case. But I also agree with that there was no need or no hurry of starting AKT, and especially even steroids with that. Because nowadays the recommendation of starting steroid has changed, and only in cases where there is a different type of severe meningitis or encephalomeningitis or such cases only, or massive pleural effusion coming very fast, then only steroids are recommended. So steroid recommendations and starting steroid, there is a very limitations of giving these steroids. Number two, there was no hurry, and one must now try to establish the microbiological diagnosis. That is a must for all the cases of tuberculosis. So one should try very hard to get to a microbiological diagnosis. And once you get that, things would be easier. But rest, everything was very well done and all discussed very well. So thank you so much and congratulations.
So the indication for steroid, as sir told, one is meningeal, then pericardial and pleural, and then the spinal tuberculosis where there is a risk of obstruction, and even adrenal tuberculosis.
Adrenal.
And ophthalmic.
And sometimes endobronchial. Yeah.
Endobronchial tuberculosis.
Yes. Yes. Thanks a lot, sir. Excellent inputs from all our experts. We really enjoyed the session, and thank you, all the learned panelists, because they have been on the spot every time with all the questions. So thank you very much. And I thank the AOP Gujarat for giving me this opportunity. We have Dr. Yagnesh sir with us. A few inputs from him, sir. Yagnesh sir.
Hello.
Yes, sir.
Hello. It was a nice presentation, Manish. Excellent cases and excellent discussion. Nice. We loved it. Thank you.
Thank you. Thank you very much, sir. Dr. Tejas, if any questions are there in the chat box,
we can take. Yes. Yes. We had a few questions. For the first case, we had a question that is it genuine to start antibiotics on the fourth day of fever? This was regarding the first case.
I think that first case, they could have waited, and always the dictum should be first send blood culture, then they should have started. And even at the suspicion of enteric fever, if they had started, the dose was improper. That is the thing. But yes, always make it a point to send the blood culture. Then if you clinically think that it is enteric, then you start, but not before that. That was the mistake in that particular case. That was the lagging.
And
So that's right.
Whenever you are suspecting any bacterial infection, try to put your provisional diagnosis, whether it is enteric or whether it is other disease, because depending on that, the dose will change. So if you had put an enteric as a provisional diagnosis, your dose will be different. So always try to put an probable diagnosis. Yeah, next question.
Regarding the second case in which the child was on ventilator, we had a question raised in the group itself, and it was also given in the chat, that whether we would have the daring to stop antibiotics after such a critical scenario when the virus was isolated. And then there was another question for the same case, that while taking a viral panel, is it possible that we may be detecting common cells?
I mean, there are going to be some common cells, but we have to, looking at the clinical condition, we have to correlate with that and then decide what it is. And here, adenovirus, once you detect, it is definitely a causative organism. So certain organisms in this panel, if they are detected, they are definitely causative. So we have to correlate like that. I mean, I told in my comment that there is no need of stopping all the antibiotics, but you can definitely reduce the number of antibiotics, and only ceftriaxone alone could have done well.
Yes, so as sir has already said, upper respiratory panel is more for viruses. Don't consider them for bacteria because lots of commensals are there. But lower respiratory PCR, if it is there, we have to take it seriously because most of the time it is pathologic organism, less likely to be contaminant or normal commensal in lower respiratory panel.
Upper viral panel, again, mycoplasma and pertussis could be there. So if they are there, probably yes, you can.
Dr. Chetan Trivedi is there. Sir, any comment from you, Secretary from PIDA?
Yeah. Excellent cases, Manish, and excellent discussion. All this, the panelists have given fantastic and very valid inputs. One or two things which came to and stuck to my mind was one was that you started that 100 milligram per kilogram ceftriaxone in the case of enteric fever first. So it is not the 100 milligram, it is 80 to 100 milligram. You have to just adjust the right dose. So you maybe having 75 to 100 milligram. 100 milligram per kilogram is for meningitis. So that is important. Second thing is about azithromycin. Now, azithromycin, many a times nowadays we see that because it takes a longer time for defervations, and we have, many a times we have panic button which getting pressed by the relatives, and we tend to make an error and then add the azithromycin. See, even if it is many a times it is showing the resistance in ceftriaxone, it works in the patient. So because we have seen one patient where it was showing a ceftriaxone resistance, but then we repeat it and it didn't find the resistance. And by that time, ceftriaxone worked. So it is not always we should be jumping on azithromycin. And there is only one study from Nepal which has been showing that ceftriaxone with azithromycin having some difference in the few hours of defervations earlier in both the groups. But we cannot be taking it as a real guideline to go for it. So that's 2 or 3 points. Else it is excellent, and experts have been outstanding as always. Thank you.
I think there are no further questions, right, Dr. Tejas?
Yes.
No further questions. Session
Sir, I
2.
just want to. So can I add one comment?
Yes, definitely.
So, just one thing, that patient with known or suspected TB warrants testing of HIV infection. I just wanted to add that.
Yes.
Yeah.
All
No,
TB
it was
cases
there.
should be
They had already done this. That's why it didn't come.
Okay.
Yeah. It was
Yes,
negative,
yes.
if I'm right.
Yes.
And don't underestimate gastric aspirate. It is a wonderful taste, and out of 10 cases of tuberculosis, at least 1 or 2 we will find positive. So don't underestimate gastric aspirate, that it will never come positive. It is just on paper. It's not like that. It is definitely useful.
And the gastric aspirate, you have to send 2 samples. If first is negative,
yes,
and the next day or in the evening again.
12 hours, at least 12 hours
second
apart.
sample.
Yes.
Manish, one question from the YouTube. How is the response of the IV cloxacillin in case of the suspected staph pneumonia, which is rapidly progressing?
Normally, cloxacillin is good drug for a methicillin sensitive. So in such a case, probably, but you cannot solely rely on cloxacillin. It has to be combined with vancomycin, because in such a situation, it is difficult to prove. But instead of that, if you combine vancomycin with clindamycin, that purpose can be solved. So,
Samir, it's done from our side.
In fact, we learned a lot from all the experts. It was very good. Thank you so much.
Thank
you,
Dr.
Tejas. Purpose of this expert connect is really solved today again with the help of the young panelists, along with the seasoned player of the experts, along with the excellent moderation by the Dr. Manish Mehta. It's really a good combination of the things what we really expected. And this is our aim and objective of this expert connect, that ultimately we have to go for our Gujarati panelists and the young generation who really deserve to come forward for this such type of the discussion. So this is what our aim and objective, and that really fulfilled today. Thanks a lot for the Manish Bhai and the whole team for an excellent presentation. Thanks a lot. Over to Anjali.
Thank you very much.
Or Hapani.
Dr. Tejas.
We had a lovely, rich academic bonanza tonight. A special thanks to all our experts here, Dr. Raju Shah, Dr. Jaydeep Chaudhary, Dr. Bhaskar Shenoy, You all have taken a big time off your busy schedule in the middle of the week. We loved your insights and inputs. AOP Gujarat is highly indebted to you, and we would expect some more guidance in the coming days also. Big congratulations to our MMM, moderator Manish Mehta, for fluently, just seamlessly carrying it out. Now to initiate and to start a discussion for 3 or more cases in detail with the help of experts and taking help of the panelists is not an easy job. I think Manish bhai, you have raised the bar for future moderators, and many would be unlikely to volunteer themselves for the post of moderator. As I already knew you, you are the master of cold toxicity, and you proved it once again. Special thanks to all the panelists, Dr. SAMIR THAKRAR, Dr. RATNA BHOJAK, Dr. DARSHAK MAKADIA, and Dr. NEHA PATEL. You have explained very beautifully about the why and how of each and every minute details. मेरी बरसों की तमन्ना थी कि पीआईसीयू में फेलोशिप करूं, आज वो फिर से आपको सुन के जागृत हो गई. देखते हैं क्या होता है. A big thanks to the office bearers of AOP Gujarat, our president Dr. Jagdish Khamar sir, our enthusiastic secretary Dr. Samir Shah, whose brainchild is actually this program AOPG Expert Connect, and Dr. Kunal Shah for taking out all the necessary documentation. Special thanks to our project in charge, plan in charge of AOPG Expert Connect, Dr. Jigen Shah, Dr. Hemant Jogani. Dr. Angelica has done a very beautiful job of coordinating everybody into this, taking care of the small things. She has been the thread among which all these academic flowers have been weaved together to have this rich academic garland today. A special thanks to Angelica ma'am also. And a big thank you to all the audience present here, without whom this would not have been possible. You have been a wonderful audience tonight, and we look forward to see you once again next month on 15th April for the 3rd episode of such a series with a different summer academic flavor. Thank you. Thank you so much.
Tejas, you have to be there in all the sessions now.
Yeah.
Congratulations to the Tejas also.
Yes.
Yes.
First movie super hit. Okay.
Wonderful comparing Tejas. Well done.
Thank you everyone.
So whole team of that our webinar series is really doing excellent work, and of course the Tejas and the Angelica is coming forward to taking this task today, and we expecting all other also to come forward for such a task. Thanks a lot.
Thank you everyone.
Thank you. Good night.
Thank you.
Thank you everyone. Good night.
Good
night.
Thank you. And
Recording is available on the
you.
AOP Gujarat YouTube. So if anybody want to check your performance, you can check definitely. Thank you.
Tejas, joy legend.
No way. The maximum fumbling which I have done ever in my life.
But
We don't know that Tejas was our first year, both mine and Manish's first year resident. So we have we go along.
He has used very rich vocabularies.
Yes.
Rich vocabulary.
Rajkot effect, sir. Rajkot effect.
Yeah. Okay, bye. Good night.
Okay, good night.
Good night.
Congratulations.
Thank you, sir.
Excellent.